I started out my presentation actually by showing our oldest literature, the long-term survival from the surgical series without any treatment. And in fact, when you look at extremely large numbers of positive nodes or very big tumors, there's a not insignificant minority who've been cured with just the surgery. So if we could find those out, who they are up front, they wouldn't need any additional therapy. So that's one direction, obviously, our work is taking us. But the other flip side to that is finding these very small tumors that still have a high propensity for metastases and treating those patients where you normally wouldn't have. So it's basically the results of all the tests to date have changed the paradigm. We are clearly moving toward finding a combination descriptor or tool that can incorporate all these factors, but we're not there yet. If you have the ability to get a 21 gene assay, I believe it only helps in decision making. Now that said, there are patients for whom I wouldn't order a test like this, and in particular those would be patients who are sure what they want to do. For example, I don't care what my test shows, I want everything done and I want to take chemotherapy. So there's that patient. There's the next patient who said, I do not want chemotherapy, I want endocrine therapy only, please optimize my endocrine therapy. And there are those patients who would not use the result. I don't believe there's a reason to order the test for that patient. Or for those patients who clearly everything is pointing in one direction and you have some urgency to treat, for example, or they have comorbidities and you would not give chemotherapy. Those are all scenarios that I would not order the test for. It would not give us any additional help in our decision making. Another important point is that it's about 1/3 of the time that the clinical factors and the biologic factors by multi-gene are discordant. So it's not an unusual situation to be in. So we are very pleased that we're accruing to all of these big trials and that we'll have some answers for sure. Not immediately, and for the person in your office tomorrow, you still sit there and have to say at the end, you know, we're going to have these answers. We're sorry you're having so much angst here, but let's try and get as much information as we can. That's the way I approach my patient care, as much as possible, and then sit down and see where we end up at the end and make our decision in a more informed way.